Hi, I'm Duane Pinto here at SCAI 2016. I'm here in Orlando with my friend and colleague, Dr. Thomas Tu. And today we're going to be talking about some interesting topics in pulmonary embolism. Tom, maybe you can begin by framing our discussion based on kind of the scope of the problem when it comes to pulmonary embolism from the perspective of an interventional cardiologist.
Thanks, Duane. You know, pulmonary embolism, I think, represents the new frontier of what we're trying to treat in terms of acute care of cardiovascular patients. Just like myocardial infarction was many years ago, we have a clinical condition that varies in severity, that can be quite fatal and is underdiagnosed. You know, many patients die suddenly and they're attributed to myocardial infarction or cardiac arrest, when in reality, if we did pathology on them, we would find that they die of pulmonary embolus. I think similar to MI, there's a lot of therapies that are tried and true, things that we've done from history that have been maintained as the status quo. But really now that we have new technologies, new pharmacologic treatments, the status quo is being challenged, and I think it's an exciting field to be part of.
I think you're right, Tom. Many of these patients actually have an in-hospital mortality that rivals or exceeds in-hospital mortality for an acute MI. And there is a spectrum of illness ranging from the equivalent of a unstable angina non-STEMI patient to a STEMI patient with severe cardiogenic shock. Can you just tell me your general schema, how you divide patients, your Tom 2 risk score for PE?
Sure. You know, I think the most useful distinguishing framework for pulmonary embolus, in my mind, splits PE into three categories. At the far end of the spectrum, you have massive pulmonary embolus, which is typically a bilateral pulmonary embolus associated with shock. That person is at the highest risk of mortality and is usually treated with the most aggressive therapies possible, such as intravenous thrombolysis. At the low end of the spectrum, you have the mild or minor pulmonary embolus, which is usually lobar or at least unilateral without evidence of tachycardia, shock, elevated biomarkers like BNP or troponin. But there's a vast group in the middle that's at least 50% of pulmonary embolus that we term submassive. And these are frequently bilateral pulmonary emboli, not associated with shock, but usually have some other biomarker positivity or sign of hemodynamic compromise, such as RV dilatation. The RV to LV ratio is frequently used as an indicator of severity of pulmonary embolus due to the acute pulmonary hypertension that occurs with this event.
And we think about biomarker elevations and other kind of features that suggest a hemodynamically significant PE, but just like in acute MIs, we're still balancing a risk of bleeding and compromise from the clot. How do you make decisions about catheter-based therapies, thrombolysis in this cohort, and what do you think are the unmet needs?
Well, you know, I feel like this is history repeating itself because for the most acute patients, we have a very old-fashioned therapy, which is intravenous thrombolysis. I feel like we're talking about STEMI all over again from 20 years ago. But we still use it. It's still a very important therapy in the sickest of the sick. But of course, as we know from history, it carries at least a 1% chance of fatal bleeding, usually from intracerebral hemorrhage. That's why it's usually reserved for patients who are at highest risk of mortality due to cardiogenic shock from the PE. At the low end of the spectrum, we have patients who could probably be treated medically, just like low-risk chest pain patients or low-risk ACS patients who may not necessarily benefit from some acute intervention. But there's a lot of gray zone in between with the submassive pulmonary embolus. And I think to sort out these issues, it's really important to get a multidisciplinary approach to how we diagnose and treat these patients, because historically these patients come from many different sources. You have the emergency room, you have pulmonologists, oncologists, orthopedic surgeons, vascular surgeons, and cardiologists as just some of the team members involved. You may be familiar with the concept of a PE response team or PERT team, which is frequently a term used to describe a multidisciplinary approach to rapidly diagnose pulmonary embolus, to categorize it, and then to agree upon a mutually agreed upon course of action.
I think these rapid response teams are very helpful. They give a perspective, not only from the proceduralist perspective, but a critical care perspective, a hematology perspective, at least in our hospital. It helps us make better decisions.
And all treatment is local, because you might have folks who are much more skilled at surgical embolectomy. You may have folks who've had no experience with surgical embolectomy. That influences your decision making. Same thing with access to support such as hemodynamic support, right-sided support devices. So there's many factors that I think have to be accounted for in your local environment.
And what I would say is, when I listen in on these phone calls or when I participate in these phone calls, by the way, we have far more of these than we have STEMIs in the hospital.
That's right. Pulmonary embolus is highly underdiagnosed because we don't have a simple, easy test for it like we do with STEMI. You can't show up in the emergency room without getting an EKG, even if you've broken your finger or you have diarrhea. But we don't do CT angiograms on all the patients who show up in the emergency room looking for PE, even though it's very common.
Well, Tom, I know you're on the cutting edge of therapies to deal with clot, especially amongst patients who might be suboptimal candidates for thrombolysis. What's next?
Well, the current therapy right now, I think that's FDA approved for a catheter-based intervention, has to do with catheter-directed thrombolysis, perhaps with ultrasound facilitation. That's a great therapy. It's been proven through clinical trials, but it does have limitations. Unfortunately, many of our PE patients are not candidates for any degree of thrombolysis. They just recently had major surgery. There's a higher risk of bleeding. So I think mechanical therapies to treat pulmonary embolus that do not rely on thrombolysis could be very helpful.
Mm-hmm. And I think, frankly, we already have the infrastructure with our STEMI teams and our rapid response teams. Some hospitals have shock teams, ECMO teams. I think those resources can be used very effectively to treat patients in the more urgent settings with PE. Of course, the time horizon for improvement when you give thrombolysis or catheter-based therapies as they are now is quite long, measured in hours or even longer at times. So I think there is definitely a group of patients who we need to intervene upon very quickly.
There's many theoretical advantages to mechanical thrombectomy without thrombolysis for pulmonary embolus. I think you mentioned several, including rapid resolution of the hemodynamic insult, where you can see improvement immediately after intervention as opposed to waiting for thrombolysis to occur. You have a much broader population of patients that are candidates for therapy because you don't have to rely on thrombolysis. And I'm working with a startup company to do a clinical trial on one such device. It's called the FlowTriever device, and it uses a wire form nitinol mesh that basically will capture clot and then withdraw it through a catheter. And of course, granted, it's limited clinical experience, but we've seen some amazing results.
I mean, I think some of these clot retrieval ideas are compelling to me because, how do you exactly deal with clot in transit, large amounts of clot proximally, where, if I had to generalize to what I see in STEMI, where we're dealing with much smaller clot, I feel like we can do better than just thrombolysis. So I think that's very exciting. I'm really interested to see how things pan out in the next few years.
Yeah, I think pulmonary embolus is the next wave of acute intervention, and I'm excited to be a part of it.
Great. Well, thanks, Tom. Thanks for helping me learn a little bit more about this disease state. And thank you for joining us here at SCAI 2016.
Thanks.